In February 2022, TTAC, in partnership with the National Consortium of Telehealth Resource Centers, hosted a national virtual technology showcase. In this two-day event, we had a variety of speakers, topics, and presentations. The following is a recording of our keynote speaker, Dr. Meskó's session featuring Healthcare Needs a Trip to Mars. We are pleased to make this recording available for your viewing.
Welcome everyone to the keynote session for today's event. I am very pleased to be able to introduce to you Dr. Bertrand Meskó, who is a PhD and the Medical Futurist and the director of the Medical Futurist Institute. He analyzes how science fiction technologies can become reality in medicine and healthcare. As a geek physician, his words, with a PhD in genomics, he is also an Amazon Top 100 author. He is a private professor at Semmelweis Medical School in Budapest, Hungary. Dr. Meskó has over 500 presentations, including courses at Harvard, Stanford, and Yale universities, and other organizations that include the 10 top biggest pharmaceutical companies. He is one of the top voices globally on healthcare technology. Dr. Meskó was featured in dozens of top publications, including CNN, the World Health Organization, National Geographic, Forbes, Time Magazine, BCC, and the New York Times. He publishes his analyses regularly on medicalfuturist.com. We will have a brief 20-minute video presentation, after which Dr. Meskó will come on live to do a Q&A session with all of you. So at this point, we'd like to go ahead and show our video. Thank you.
Welcome, this is Dr. Bertalan Meskó, the Medical Futurist, and thank you so much for the National Telehealth Technology Resource Center for the invitation to take part at this virtual event, and to allow me to talk about one of the most exciting topics these days, the near future of digital health and telehealth in general. I can only imagine the toll the pandemic has had on you because of the pressure to bring in telehealth technologies and services into the everyday practice of medicine, the everyday delivery of healthcare. I'm not here to put even more pressure on you. As the Medical Futurist, my job is to provide the context, the big picture overview about where healthcare is heading, what digital health really means, and what it will mean for the near future of healthcare when we get out of this pandemic. In the meantime, I will try to give you a few real-life good examples, maybe a few approaches and points to keep in mind while we bring telehealth into the everyday practice of medicine. Because let's have no doubts, telehealth is not just a technological gimmick, something new and exciting. Telehealth is going to be one of the major forms, the essential component of healthcare in the near future, especially as we get out of the pandemic. So let's dive into that. And I know I have a weird title for you today, but let me explain why healthcare needs a trip to Mars. There are many industries and areas where technologies have been becoming real, like something out of science fiction. We've been talking about technologies like 3D printing and how we could print out even full structural houses. And now you look at Chinese and US companies being able to print out full houses in less than 24 hours. We've been talking about how certain technologies could make people superheroes. And now in a ship factory in South Korea, ship workers have to put on an exoskeleton, robotic structure, and they can lift huge weights with that. We've been talking about self-driving cars, and now tens of thousands of cars have been roaming around the US, many trucks have been roaming around in Europe, and those are all self-driving vehicles. So these advanced, sometimes science fiction-like technologies have been becoming real, but there is one even bigger thing to come. The biggest technological advancement yet. We will colonize another planet. I can't see you now, but I hope you are as excited as I was as a kid back then learning about this idea that one day we might colonize another planet. I was so excited that someday it could happen, I could literally cry out of excitement. But now Even if you're not excited that much about this idea, let me tell you something exciting. You are one of the first colonists to Mars. I hope you know what it means. It means your physical health is amazing. Your mental and emotional health are off the charts. You can work with groups of people. You can work without anxiety or depression. You can focus when you want to. You are extremely smart. You are extremely healthy. You inherited good genes from your parents. So, congratulations is in order because you are one of the first colonists to Mars. We can now make that feat happen because SpaceX has made reusable rockets a possibility. Before, every rocket was just going into the ocean to waste. But now we can reuse rockets for 100 times. Can you imagine how many millions of dollars we are saving with that? With that technology, we can get to Mars in about 4 or 5 months. We, the first colonists, will bring and build something new to another planet. I can tell you that it's quite a dangerous environment to live in. It's very hot in the daylight, it's very cold during the night. It's a dangerous environment, but we have a protective spacesuit to protect us from these dangers. We have a hub, we can now grow plants and create our own food. And when you go out there around the hub to look around, you can see Earth rising up on the sky. It's pretty exciting. It's something different than what we are used to back on Earth. So now we are enjoying this amazing historical moment. Within your spacesuit, you can access data, your health parameters and vital signs and data about and information about the environment, and you can communicate with your peers around the planet. It's amazing. But then, as always, something bad happens. You just can't see properly. I mean, you don't have any pain or the symptoms, but you can't see properly, and you are sure it's not something on your spacesuit. It's something about your vision. What do you do when you are in a medical emergency? You let medical professionals know around you that something is wrong. So, as you were told, you let mission control back on Earth know that something is definitely wrong because you cannot see. But it will take your message 20 minutes to get to mission control. If they ask something, 20 minutes more, you answer the question, 20 more minutes, and then even if they give you the final answer, it took 80 minutes for you to get medical help while you are waiting in one of the worst parts of your life. No. While you let mission control know what's going on with you, you also let your colleagues know around the hub in just seconds that, guys, come out and please bring me in because something is wrong about my vision. They bring you in. You don't have all radiology devices. We couldn't bring a CT or MRI scan to Mars. We don't even have all the medications you might need because of limited storage and supplies. We have a few medical professionals on board, but not from every medical specialty. That's why we have to keep on relying on mission control back on Earth. Let me summarize what's going on with you. You are in one of the most vulnerable states in your life. Someone from afar is making a decision over your head. You are not being engaged and involved. You can't access all the medications, the radiology devices that you might need, and there is not much time for empathy. Sounds familiar? I'm afraid an astronaut stranded on Mars would receive the same kind of healthcare and would go through the same experience as a patient back on Earth today. And I hope that's the most awful thing I would say in this keynote. But if healthcare is in such a bad shape, especially during the pandemic, because of the toll on frontline workers and the pandemic fatigue coming out on healthcare professionals, because of the debates about misinformation and anti-vaccinations and all these, then the solution is also simple. We have to build a healthcare system that would keep even an astronaut on Mars alive. So let's get back to Earth, to our practical reality, and talk about what kind of healthcare system we should be building here. I think that healthcare system should entail at least 5 major features. First, it should be accessible, physically and financially. It should be personalized because it should be customized to your genomic, metabolic makeup, to your lifestyle insights and habits. It should be preventive because it's always cheaper to prevent something than to treat something. It should be augmented, physically and cognitively, depending on the medical specialties we are talking about. And maybe most importantly, it should be more humanistic than ever. Even if we find ways to implement a range of advanced technologies into healthcare, if we lose the core values, then we lose everything. We did a study at the Medical Futurist Institute with the world's 15 most forward-looking, most empowered patients, and we interviewed them about how they would like to see their doctor-patient relationship in the near future. They didn't ask for artificial intelligence or smartwatches or more sensors. They asked for the same three things: attention, empathy, and time, the core values of practicing medicine. So I think my job as the medical futurist is to talk about how to find that balance between implementing more and more advanced technologies while very much keeping the essence of medicine and healthcare intact. You might ask, why don't we have such a system already? Well, I think the answer is quite simple. About 200 years ago, at the dawn of modern medicine, there was an implicit contract between healthcare professionals and society. Society claimed that we would keep on financing healthcare and respect your autonomy, physicians, but dear physicians, in exchange, you should guard over the health of patients. I think more or less it worked out quite well until the 21st century came. Then something big happened. Global supply chains became a real thing. Social media paved way for second opinion, peer support, online community sites. Now we can access information and data. The ivory tower of medicine started breaking down. Therefore, a new contract is needed. And that new contract is called digital health. Digital health would bring us into the 21st century. But as you can imagine, and I think as you see it in practice, there are some major hurdles to overcome. The first hurdle is about the idea that healthcare was never designed to be open to technological innovations. A few things explain this phenomenon. One, 5 million healthcare workers are missing worldwide. It means that you and I will always live in a world with doctor shortages. We will never train as many healthcare professionals as we need. It means even if we have more and more patients requiring medical help, and we have still more and more physicians trying to provide that medical help, the gap between them is just going to get bigger. One more thing, lack of trust. 1/3 of patients keep turning away from us towards alternative treatments. Those treatments only have, one thing in common: time. No efficiency, no safety, just time. Time that we cannot provide patients with. And the third point here is that, as always, there is a financial issue. If you live in a country with socialized medicine, I know you don't, but I do, and it means for me that I can access healthcare immediately, but there is not much money left for using innovations in my care. If you live in a country with a private insurance system, you can access all the innovations you want if you are wealthy enough. Right now, the 1% wealthiest Americans live 10 years longer than the bottom 1%, and that gap is just about the access to care. Imagine how big that gap is going to get when the issue will be more about you can access a 3D bioprinted liver tissue and I have to wait for an organ transplantation, someone to die. You can go back to work after an accident in an exoskeleton, quite expensive one. I cannot do that, so I will not be able to work maybe ever again. That gap will be a nightmare dystopic scenario, which we shouldn't allow to happen. But for these minor reasons, healthcare was never designed to be open to technological innovations. Even if it would be a bit more open to such innovations, I'm sorry, then come us. People working for healthcare. We adopt things, but it takes so much time. Look at the stethoscope, one of the simplest technologies out there. 200 years ago, that's how we listened to cardiac and lung sounds. We had to put our ears to the back or chest of patients. Then a French professor, Laennec, saw his kids playing with a hollow wooden tube that would augment the sound. So he started using it. It took him 30 years, 3 decades, to get his message across, because medical associations worldwide claim that they didn't want to use a gadget while practicing the art of medicine. But if you have a stethoscope around your neck today, you must be a medical professional. It has become the symbol of being a physician. Yet, before we had 30 years to adopt one medical innovation, and now, today, there are 30, if not 30,000 innovations coming out every day. Nobody is prepared for that. There are a few medical curriculums worldwide preparing students for working with such an amount of new technologies, but most of us are left alone. Then comes the third reason why we don't see digital health yet. It's easy to be afraid of the unknown. And by the unknown, I mean, of course, the biggest thing to come. Not health sensors, microchips, but automation. Let me give you just a very short story about why the same thing will happen to healthcare because of automation as what has happened to chess. In the 1990s, Garry Kasparov, the best player back then, had a match with IBM Deep Blue, a supercomputer, not even artificial intelligence yet. It was a very, very important match. News writers, reporters around the world came to the match to see humanity against computers, the final big battle. It was a long match and Kasparov lost that battle. And many news writers even claimed that, well, that would be the end of chess. Who would like to play chess ever again when the best chess player is an algorithm and not a human player? Well, the truth is that today about 600 or 800 million people play chess every day, myself included. Every chess player, literally all of them, have to work with AI to become better at their games. Every chess coach must use AI to better prepare their students. And even just people who like watching tournaments live, like myself, we need the evaluation that AI provides us with to try to understand what might be going on in the minds of chess grandmasters. In short, AI has made chess better, more competitive, and more popular. I think the same fate awaits healthcare too. No patient, no healthcare professional, no policymaker will be able to build healthcare or take part in healthcare or take care of others without using some form of automation. And that was a story just about chess. When it comes to even more complicated games like Go, where there are more potential board positions than the number of atoms in the universe, you soon realize that you will need different skills besides automation. Maybe intuition, creativity, purely human skills. And that's what happened when the so-called AlphaGo algorithm could play against and beat the world's best Go player, the 18 times world champion Lee Sedol. So we have to say out loud at this point that there will be tasks where we couldn't and maybe shouldn't compete with artificial intelligence. For these three major reasons, we think that digital health is not a technological revolution. It's a cultural transformation. I mean, it was initiated by the advance of technologies, but it's not driven by them. The way digital health leads to an equal level partnership between patients and caregivers matters so much more than which smartwatch or microchip comes out next year. The way it leads to new roles for patients from the passive role to be transitioning into a proactive, empowered patient role, it's so much important. The way the role of physicians from being the key holders to the ivory tower of medicine to transition towards the role of being a guide for their patients in the jungle of data and information. These changes matter the most, not which technologies would become accessible next year. And we publish a definition of digital health too. Digital health is a cultural transformation using technologies that provide data to both patients and their healthcare professionals, leading to an equal level partnership and, on the long term, the democratization of care. The shortest form I can summarize all these things into is that digital health makes patients the point of care. And as you can imagine, telehealth points into the same direction. Before the pandemic, we had this idea about where digital health was heading. But then the pandemic led to something very surprising, an incredibly quick technological adoption. Millions of patients and physicians worldwide started adopting telehealth-based technologies. Not out of a choice, but a must. But still, the technological adoption took place in weeks, maybe months in 2020, but the cultural transformation is still lagging behind. And if we don't learn how to build a relationship with patients through these technologies, then we lose everything on the bargain. So that's why it's important to acknowledge that a cultural transformation is going on. And that's why I thought that at the end of my keynote, I would just summarize all these things into 3 practical approaches, 3 actionable steps that might help you better implement these technologies and not lose what's really important in medicine and healthcare. The first point is about patient design. I know every company in healthcare today is patient-centric. It's great. But patient centricity is a passive process, while patient design is proactive. Let me explain. When you ask patients what they want to see in a final design, the final service or product or technology that you're building, whether you involve their decisions in the final design is your decision, not theirs. They are passive components in that. But in patient design, you involve patients on the highest level of decision making in the organization. That's brilliant. I was invited to a Dutch hospital to see this in action. They opened up a new facility for the hospital, and before doing that, they invited their chronic patients to have their voices heard. They did. Patients asked for a round table, not the traditional word desk where, as a physician, I can access all the data, the monitors, the books, and everything, but the patients only see the back of these things. No. Let's have a round table accessing the same interfaces, the same data. When we are done, we can go to a professional place within the same room. Patients ask for a designated area called the clinic where a physician can examine a patient. When they are done, they go back to being equal partners around the round table. They told me that patient satisfaction has been skyrocketing because these patients feel that they are members of the medical team. Physicians love working in this space because for them it's less stress, less burnout. Patients come with better questions and fewer questions, and even their compliance is higher now, we know, based on studies. And as a good Eastern European, I had to ask about the cost of patient design. I was told it's an IKEA table, like $50, and blue duct tape on the floor. That's the cost of patient design. So now we are pushing every healthcare, biotech, pharma and medical company, every healthcare government and policymaker and regulator to implement patient design, to have patient advisory boards on the highest level of decision making within their organization. In the case of telehealth, it's even more important to acknowledge that specially designed rooms and environments are needed to be able to conduct good telehealth services, to be able to build relationships with patients through this technology. It cannot be just implemented like that in a hospital setting. Specially designed rooms and environment would be required for that. The second point is about how we can learn to allow good technologies to augment what we do. In that sense, it's quite important to point out, after I described how the roles have been changing, that the toolset that we have to use is also different today. For centuries, medical professionals have been trying to translate information, answers, data obtained about patients into actionable steps: diagnosis, monitoring, treatment, using an array of quite analog technologies. But now that toolset is vastly different. Genomic data, artificial narrow intelligence, health sensors, portable diagnostic devices, portable ultrasound devices, a huge amount of technologies point into a direction that we could be able to provide care wherever we are, again, making patients the point of care. The major transition that has happened because of digital health can be summarized in two images. One is that the point of care we all know, where again we can access data patients cannot. And the one that we might have soon, and in many places we already have today, is this: patients and medical professionals on an equal level partnership discussing a health issue, building a relationship. And the same should apply to telehealth services. Nothing is different. If I was told as a physician that from today I can only interact with patients by looking through the window and they will be outside and that's the only way we could communicate, I should still be able to learn how to build a relationship with them, how to care for them, how to solve their medical issue. Telehealth, that's why telehealth is not just a new technology on the horizon. Telehealth is just a form of communication. And as patients very much want to become the point of care, some of them out of choice, because it's simply more convenient for them to do that. For others, out of must, because they couldn't access care at all without telehealth services. Let's say out loud that telehealth is going to be very much part, an essential component of the new norm we are building after the pandemic ends. But we cannot lose touch with patients, we cannot lose connectivity, and we cannot lose trust. We have to be able to learn skills, acquire skills that would allow us to provide a similar quality of care even through telehealth services. And we will need plenty of things to keep in mind why that is taking place. One is that digital health technologies also make healthcare globalized. One more point underscoring the importance of telehealth services. Just one short story about that. A patient from Japan today could transmit a biopsy sample, a cancerous tissue sample, to a startup in Belgium, where they could sequence the DNA of that cancerous tissue, looking for so-called driver mutations in the US cloud. And maybe there is a Australian pharma company running a clinical trial on a Spanish island, which means the patient could receive state-of-the-art precision treatment for their type of cancer for free, without meeting anyone in their own healthcare system. That's not ideal, but that's how these technologies make healthcare globalized. One more thing about digital therapeutics, a really new trend in digital health. Digital therapeutics stand for prescription medications that can be coupled with digital health services. An app on a smartphone, a sensor, a service, a direct-to-consumer test, an at-home lab test. It's quite a whole huge range. But even some healthcare providers started paying more, rewarding more these medication plus digital health technology packages than just medications alone. So that's what we have to get prepared for, including mental health, other types of telehealth services being packaged with prescription medications. And all this would only become possible through the use of artificial narrow intelligence. No human being would be able to analyze that amount of data. So we will need automation to help us out in that. But please believe me when I say that AI will not replace physicians. However, I firmly believe that those physicians who use AI will replace those who don't. That's how simple it is. But I also want to make sure you understand what kind of AI I'm talking about when I refer to that expression. I'm talking about an algorithm that can perform a very well-defined single task. It's far away, maybe decades away from artificial general intelligence that could match your cognitive capacity. We are far from that. But artificial narrow intelligence is here and is today. If you have doubts about that, just look at the study we published at the Medical Futurist Institute about all the FDA-approved AI-based medical technologies. You can see certain medical specialties stand out already. I mean, radiology, oncology, and cardiology do stand out, but there is a huge range of AI-based technologies being approved by the day. We found about 70 of them, now there are more than 100. Artificial narrow intelligence is going to be an integral part of practicing medicine. So if you worry about how to implement telehealth, I don't want to threaten or frighten you, but you might also want to start thinking about how all these other advanced technologies will play a role in bringing telehealth into the everyday delivery of healthcare. But the point I'm trying to make here is that the vision we have at the Medical Futurist is not a vision of a doctor and a patient having a discussion while having more and more gadgets in front of them. No. We want to remove every interface. Just leaving two people having a real-life conversation, building trust with empathy and compassion, while they should be surrounded by advanced, seamless, nearly invisible technologies. Chatbots in the cloud, smartwatches, health sensors, portable diagnostic devices, artificial narrow intelligence, anything that could help these two people make better decisions while again building a real-life relationship. The same should apply to doing patient visits and having discussions with patients through telehealth services. The technology is different, yes. The ways of communications are not so different, but the values should be absolutely the same. And that's why, in my third point, I just want to make sure that you understand your patients from the near future. People like me, who want to dedicate time, effort, energy into their healthcare system. I very much want to get engaged with my lifestyle management, with my healthcare in general, with my disease management in the future, because I want to have a chance for a long and healthy life. I have a partner primary care physician in that. Plus, with a range of technologies, I can measure sleep quality and have a smart sleep alarm to wake up at the best time in the morning. I'll be measuring my fitness activities every day to motivate myself to exercise more. I could measure stress levels or meditation levels through EEG, headbands. I had my genome sequenced to learn what kind of diet and what kind of lifestyle I should have based on that. which medical conditions I have a risk for, which medications I would have a side effect for, so let's avoid using them. I even had my microbiome sequenced to learn how to adjust my diet to the bacteria living in my digestive system. Can you imagine how much data I have to handle with that? Can you imagine how easy to feel lost in that jungle of data without the expertise of my healthcare professional? Can you imagine the privacy challenges and the security challenges I face every day? Or just Bluetooth connections? It's really awful. But I want to have a chance for a long and healthy life. And I'm pretty sure that in my healthcare, telehealth will be the normal form of healthcare delivery. Because let's be honest here, it has been a luxury already to be able to meet a healthcare professional with even minor health issues. With doctor shortages, with all this cultural transformation, not all patients will have that luxury. You will have to turn to remote care services, and that should be perfectly fine because we can provide the same quality of care in the vast majority of cases. Not every case, but the vast majority of cases. And these have been just a few examples about how many technologies patients can reach out to. I personally tested more than 100 digital health gadgets, sensors, and services, and even more will come. You can be quite certain about that. But by knowing all these 3 points, I think it's time to come back to our astronaut, because now we know what kind of care he or she would need. He or she would need a healthcare system that would make sure that nobody suffers from side effects, bad decisions, or the lack of information. And if you can build a colony on another planet, and believe me, we will in about a decade or so, we should be able to build a healthcare system that can bring the chance to patients to live longer and healthier lives. That could bring the chance to medical professionals to enjoy again why they became medical professionals. And as we head into a new norm after the pandemic ends, it makes even more sense to keep on talking about implementing such advanced technologies into care. Thank you so much for your very kind attention, and I now look forward to the Q&A session. Thank you.
Thank you, Dr. Meskó. That was a great presentation. And now we actually have Dr. Meskó live, who can answer the questions that we have for him.
Absolutely. Thank you so much for having me, and I very much look forward to the great questions.
So one of the questions that I have for you, Dr. Meskó, is you discuss a jungle of data that we are gathering from the patients. How can we navigate that jungle of data effectively and efficiently?
Wow, what a nice question to start the Q&A with, and it's quite a challenging one indeed, because my answer would very much vary based on who the we is referring to. If it's a patient, I would say that we need to turn to our medical professionals for guidance. As I mentioned, they have to become guides for us in the jungle of data and health information. If it's about medical professionals, they need guidance from the medical associations, from the healthcare governments, to learn the skills needed to become guides for their patients in the jungle. If you're talking about policymakers, they have to keep on relying on technologists and inventors and those who have been trying to develop new technologies at companies and understand better what kind of technologies they can come up with, so how they can better regulate what might come next or what might be brought to the market soon before it even becomes accessible. But in general, I understand what the question might imply. I'm afraid there is no miracle solution for this. I'm afraid it's going to be a learning curve for all of us. But literally, the sooner we try to dive into the jungle of data we can measure about ourselves, and the sooner we go through that learning curve I described in the keynote about being anxious when waiting for a genetic test result or just being lost in that amount of data, I think still the sooner we can find the solutions that work for us. For me, as a geek at heart, which is, I think, a positive thing to say out loud, I can analyze my data, but I still get lost without the expertise of my healthcare professional. So I think we have to turn to these digital health technologies and start obtaining, measuring data to see what kind of challenges we face first. We won't find solutions first, I guarantee you that. But then maybe we could build a better relationship with our physician through the feeling of being lost in that amount of data.
Dr. Meskó, I'm going to take over asking some of the questions for us here. So we had a really good question come in from Michael Kurland. I'm going to show this on stage. So when it comes to cultural change in healthcare, what's really slowing us down and what can we do to address it?
Thank you, Michael. It's a very smart question to ask, and I'm smiling because there is no elegant way to answer the question other than saying that we are very bad at changing. By we, I mean people working for healthcare. The tradition we've always had has always been about not changing fast because of evidence-based medicine, because of the way healthcare works and the amount of regulations we have to face, and because patients' lives are at stake. We don't have to change that fast. But cultural transformations need change in the roles, as I mentioned, in the tool sets, even in the approach, that the way patients and physicians approach these new technologies. All these things lead to changes. And if we don't like change, this will just not facilitate the adoption of these cultural shifts. But maybe if we start talking about these fears we might have about change, or if we try to understand why we don't want to change in certain situations, I think it can lead to better shifts in the cultural transformation. That's why whenever I work with companies trying to find out why certain types of medical professionals reject or resist this cultural transformation we call digital health, the question I ask them is not why don't you do this or that? The question is, what kind of feelings do you have about these changes? And maybe if we understand those feelings better, maybe we can make better decisions for them to further accelerate or facilitate that cultural shift.
That's great. We've had a few questions come in talking about designing a space for patient care with telemedicine and clinic work. I'm going to show this one on stage. What advice would you give to a small clinic or hospital that does not have the resources to adopt a customizable telehealth approach to healthcare? And if we could answer this from a kind of a facility design perspective, as we've had a few questions come in that way.
Absolutely. Thank you so much for this question. It's quite a hard one to answer because for this, I should have more details about the exact healthcare institution we are talking about. But in general terms, I think in such cases, in small scale cases, we should turn to those devices or technologies that my healthcare workforce already has, and not look at buying new stuff for the hospital. I'm talking about the smartphones that most physicians have today. And that's quite a good resource we could use, but we still need specifically designed rooms for conducting telehealth or remote care visits. I'm not talking about redesigning parts of the whole facility, but I do refer to creating spaces for physicians who this way would be able to conduct telemedical visits in a quiet place with good lighting, very simple stuff, with good bandwidth, good internet connection, and this way they can focus on the patient. Because the only thing I would keep in mind as a healthcare leader is that if my healthcare workforce, if my physicians have to keep on focusing on dealing with the technology, there's zero chance they could build relationships with patients. But if I at least give them a space, a design-based environment that would allow them to focus on the patient, no matter what technologies they are using, it still sounds better to me than focusing on the first option.
That's great.
There are some really great questions coming in the Q&A session, the Q&A section of the chat.
We've got quite a few. I'd like to ask this question here. You talked about invisible technology, and can you give us some of the attributes of what makes technology invisible? What kind of makes it disappear?
I'm smiling because thank you so much for pointing that part, that feature out. I guess it stands out of the three features I use. I think I said those technologies must be invisible, comfortable to use, and we should be able to implement them properly, smoothly into the settings. Invisible is the most futuristic term out of these three major features. But by invisible, I mean that if you give a patient today a digital health-based technology and they have to start dealing with Bluetooth connections and downloading data on their smartphone and connecting the app to the hardware device through a Bluetooth connection, stuff like that, they won't enjoy using those devices. They won't feel that these are like invisible devices. So by invisible, I mean, of course, not physically invisible, but those we can just wear comfortably without any hassle, without dealing with the technological side of using those gadgets, without dealing with Bluetooth connections or the hassle of downloading the data. Just wear something like a digital tattoo, and if there is something wrong or about to go wrong, give me a notification on my smartphone. That's something I would call invisible. But I'm not saying we are not moving into that direction, but I'm saying that I'm looking at my 4 shelves of digital health gadgets on my right, almost 100 digital health technologies here. None of them is invisible. But for example, in the ECG section, I'm talking about smartphone connected ECGs, there has been an evolution of making the devices smaller and smaller, thin like a business card, like a bank card, and now they can work smoothly with the smartphone. So we are getting there. It's just not it's not happening as quickly as one would expect.
Here we have a question about AI and how do we make it more accessible for patients and providers? I think you're muted, Dr. Meskó.
I didn't click on anything, but I saw that it just became muted, but now I'm unmuted. So hopefully you can hear me now. So AI is explainable today. When it comes to artificial narrow intelligence, it is very much explainable. The question is not whether is it possible to explain that level of AI we have today. The question is, even if we can explain it in the simplest possible terms to medical professionals, would that be enough based on their general medical knowledge to gain enough trust? But then I'm having a discussion with myself. The way I would answer that question is that in biophysics, when I was a medical student, I learned how the magnetic resonance imaging machine works. I learned all the spins and all these. I couldn't describe to you, even though I got the best grades back then. I guarantee you that 98% of physicians cannot describe in details how the MRI machine works, but they have a high enough or good enough scientific knowledge about that technology that they have enough trust with the technology, so they would smoothly send their patients to that machine, not thinking about, not having fears about what damage the machine could do to those patients, even though they couldn't describe to you how that works. I think we have to reach the same level of trust with artificial intelligence, that you understand it enough to gain trust, even though you couldn't describe in enough details, like a developer or an inventor, how that technology works. And that's a level of trust it's very possible to reach today.
That's great. Can we talk a little bit about bandwidth and how that has impacted or we can potentially impact care for patients?
Yeah, you will not like me for trying to avoid the question, but I try to be very cautious about making a distinction between health IT and digital health. There are health IT issues which people like me have nothing to do about. It's an infrastructure issue. Healthcare governments have to invest more into that. And saying this out loud confidently, I know it sounds very weird, but we have better bandwidth on average in my country, in Hungary, than you in the US. And I know it sounds awful, but that's a physical fact. Health IT issues are issues that healthcare government should take care of. Digital health issues are different. Those require new regulations plus approach, skills, new roles from medical professionals, from inventors, developers, patients themselves. And the way I try to make a distinction between health IT and digital health is by using the Gary rule, which we published not so long ago. If you can call Gary the IT guy to help you solve an issue, it's a health IT, and he can solve it, it's a health IT issue. If Gary is not enough, because maybe you want data from a wearable tracker from a patient to be brought into the medical record system, Gary won't solve that for you. That's a digital health issue. Bandwidth belongs to health IT issues. So I couldn't give you digital health-based solutions that would improve those issues, I'm afraid.
I love that distinction. That's a great way to think about that.
The Gary rule.
I know you can speak to this, and I know you have sent out a lot of resources around this, but if you could talk about some places to stay informed.
Absolutely. The simplest way of answering the question is that I can give you a list of resources that I stand by. Of course, I would come first with medicalfuturist.com, where we don't advertise, we don't have an agenda, we just want to help medical professionals, patients, policymakers out there better understand these new technologies. But I would also list medgadget.com, mobihealthnews.com, these amazing sites. But I don't think just going to those sites and reading news would help a medical professional better understand those technologies. I think what's needed for that is a new skill, forecasting. It might sound weird why a physician should learn the skill of forecasting, but I think it's crucial. And forecasting essentially helps everyone get a better image about what might come next, because many things will come, many new things will come next. And even if you learn about a technology today, doesn't mean that you will understand the further evolution of that technology later on. But if you have the skill of forecasting, you can better deal with changes in your field of interest. And the best site, the best way or resource to learn the skill of forecasting is called the Good Judgment Project. Let me give you the exact URL. I'm there every day, but I don't know the URL by heart. gjopen.com, goodjudgmentopen.com. It's a free community site where people like me, professional futurists, retired teachers in Germany, athletes in the US, people who would love to deal with forecasting come together, and we have to answer questions about geopolitical outcomes, sport events, culture, technological issues like how many electric cars will China produce next year. And even if you have zero knowledge about that theme, that field of interest, if you start dealing with gathering information about how to answer that question, and the community will help you so much in that. It's a very supportive community. Question by question, I guarantee you that you will learn, you will acquire the skill of forecasting. And from there, it doesn't matter which resource you look at, you will make better assumptions on your own.
That's great. This question's about telehealth and demographics. Can you talk a little bit about how technology allows us to handle patient demographics and adjust our care based on the patients we're serving?
I guess the question implies, which challenges we should focus on. So I'll try to focus on two challenges of the demographic demands. One is about age. And what I've come across over the years when it comes to adopting telehealth for elderly patients is that they adopted such solutions the same way they adopted those to be able to keep in touch with their family members, their kids and grandkids. And even though it's still a challenge, we can't expect elderly patients to learn this on their own. That's why their physician should be able to guide them through this process. I'm not talking about IT customer service. I'm talking about physicians who have built relationships with elderly patients, and those patients who trust those physicians. So when it comes to using telehealth, they can help them. Physicians can help patients understand that it's just an other form of communication. It's like if because of a pandemic, I wouldn't be able to meet you face to face. So you should stay out of. I know it's a silly example. You should stay out of the hospital, but by looking out the window within the hospital, you could still talk from afar. Why is that different from having a remote consultation through a telemedical service. And that's why they should act as guides for those patients. Regarding another demographic demand about low resource regions, the good examples I've seen in that area have not come from the technological side of this story. But the best example I've seen was about Australia or New Zealand, where they trained an army of so-called digital health mentors. And those trained professionals had to go to those low resource regions and help patients living there find out how they can use the technologies they already own. So because they don't have enough money to buy new ones or better phones or better internet connection, but based on what they have, how they could improve the health and digital health literacy of patients. And it's quite maybe surprising fact that there is not a technology that could help fill that digital health literacy gap, but it's actually people talking to other people. That communication solution would be the one that could fill that gap, but it has been working out quite well. So for those regions, I would train an army of digital health mentors to try to close a bit the digital health literacy gap.
I think we have time for one last question. This one is related to a specific virtual technology, but I'd like to maybe expand it a little bit more to include maybe augmented reality, virtual reality, and those sorts of technologies.
I do believe that it has a chance or potential, it has potentials for the midterm future. But as someone who has been in the metaverse for 2 months now, I bought my first virtual reality gear 2 months ago to really dive into this space. I must tell you, all my geekiness has been needed to get something out of that experience. And instead of taking part in virtual communities in the VR setting in the metaverse, I've been playing table tennis. It's quite a fun experience, and it's very efficient and very, very surprisingly accurate. But to use the metaverse for such consultations, I think it's so far away. Just if I have to give you a reason why, I would just make every one of you, I would give you a VR gear now, which should be very intuitive to be used. And I would ask you to just log in to a social community site in the metaverse. It will take you a lot of time, no matter how good you are with technologies. I'm very good with technologies, and it took me a lot of time. It's not intuitive, it's not user-friendly. It's fun, but I don't see how the metaverse could become part of patient assessment for now. I can see the use of VR for some evidence-based reasons, like reducing pain for patients staying in the hospital for longer times. We have enough studies to back that as a proof of evidence now. But in other ways, just for communication, a text message is so much more useful than making people log into the metaverse that I just don't see that happening in maybe 5 to 10 years at least.
Well, I really want to thank you for your time today, Dr. Meskó. This has been a great session. We've had a lot of really great questions come through the chat. Again, I would recommend that you follow Dr. Meskó if you haven't. He's on LinkedIn. He's on a variety of social media platforms. He's always posting really interesting resources and things for us to learn from. So again, thank you so much for your time today. We really appreciate you speaking with us.
The pleasure was really mine. Thank you so much for having me and for these very insightful and exciting questions. I hope you have a great day and a great event.
Thank you.